conference. KDSG is a small body, and we started these symposiums 4 years ago. This is the 4th one. And as you well know, for 40 million people, we have a handful of diabetes and endocrinologists. There are actually just about 15 of us in this country. And this is a growing field. So we are excited to celebrate 50 years on. If you check the theme, it says we are celebrating 50 years on. And this is 50 years from when medical training began. So this conference will be a celebration of some of our faculty, many of us who trained here, and just celebrating the speciality and expertise, not just in diabetes, but practitioners and our nurses and everyone else who has trained in Kenya. We have a distinguished faculty who will be coming, and you will meet them all in the next 2 days, from both local faculty and external faculty. We have a wide range of speakers and sessions going on, which should be enjoyable for everyone. So on behalf of the Kenya Diabetes Study Group and the organizing committee, it gives me great pleasure to welcome all of you. I want to thank our executive team. At the beginning, usually we don't begin with a vote of thanks, but I want to thank the team who have put this together. We shall meet them all as we go along. But we say notable among the recent developments of in the country is the increasing interest in diabetes as a subspecialty. This morning, Stan Lindau from South Africa said it's one of the biggest growing, is it careers or professions? Because diabetes is one of the largest epidemics now facing us globally. So we're excited that we have a younger faculty growing in this area. So the scientific sessions will be delivered by well-acclaimed speakers, both local and international. And this year, something we haven't done before is a Young Researchers Forum. So this afternoon, we will have 4 different presentations that are local work done in Kenya by doctors here. So that should be exciting, and we hope this will grow in the years to come. So we hope this conference will be an opportunity for you to make new contacts, meet new friends, and establish new collaborations. And I would like to thank our sponsors and everyone who has been part of planning this over the past year. So I wish you all a stimulating and enjoyable conference 2018. Thank you for being here.
Being a pediatrician and pediatric endocrinologist also, one of the things we are very passionate about is that we want our patients to be responsible. We want to empower them to take care of their illness. But today I'm actually going to be talking about management of type 2 diabetes, and more so specifically talk about the structured blood glucose testing, because I think it's important in an area where, as we know, that diabetes is a chronic illness. They're going to have it for the rest of their life once diagnosed, and that it's also a financial implication, that you need to do it knowing that what you're doing is actually going to give you a result, and it's actually also financially doable. So, sorry, just 1 minute. All right, let's go. So how much does a patient take in terms of taking care of type 2 diabetes? One, we know that type 2 is a chronic illness, that's for sure. We know that it's a lifelong illness, and then we also know that it's actually progressive. So initially, most people start with 1 medication, sometimes 2, and sometimes eventually, when you're trying to optimize care, back into insulin. So for us, it is important that patients actually take control of their disease, and they know how to actually manage the disease. So just to go up, because I'm going to be the first person, remember that adults present with type 2 diabetes all the way from being metabolic disease to all the way to diabetes. And to be able to talk about that, remember, by the time someone is being diagnosed with type 2 diabetes, that illness had started almost 12 years prior to that, in terms of the beta cell destruction happening 12 years before that. And to explain that, I'd like to use this curve. Remember, I talked about 12 years before the diagnosis, and this is at diagnosis. So initially, you have good beta cell function, and remember, beta cell function is the one that produces insulin. You have good insulin secretion, and the resistance of insulin is not bad. So your fasting sugars and also your after meal sugars are actually okay. As the disease progresses, your beta cell function reduces over time. While the beta cell function reduces, what happens? Your insulin secretion initially will increase, and then what happens? It starts going down. We're together until there? And as the insulin secretion goes up and then goes down, what happens to the blood sugars? The first thing that gets affected is what? The after meal sugars. We're together until there. So you'll start seeing that people are not being able to keep the sugars properly after the meals, and it keeps on getting worse as the insulin goes down. And you can be able to see that as the insulin actually goes down. Next thing that gets affected is the fasting sugars. By the time someone is diagnosed with type 2 diabetes, two things usually happen. A lot of them will actually have microvascular complications, and over time they also start developing macrovascular complications. We are together until there. So by the time someone is diagnosed, we know that this disease had actually started much earlier on. So at the very end, Fong actually reported that 2 to 3 years after diagnosis, majority of the people, in order to be able to get them optimal care, they will have microvascular complications and retinopathy. So Anna got very scared because of the low sugar. On the next day, decided not to take any insulin. That's the reason that happened at that particular point. And then took the insulin on day 3, and what happened again? Low sugar. So what would you advise, even before she comes to see you, that Anna needs to do? Because she's getting low blood sugars after the morning dose. Sorry? Anyone? What about the breakfast can she do? Morning dose, she can reduce the morning dose. Increase her breakfast portion to more complex carbs. Anything else she can do? She can take a snack. Or the other thing also is also be able to eat also her lunch much earlier. As other reasons she can be able to react in terms of that. Let's go to the next one. I'll have to help you again. One of the things that happens, so this is the normal. It's between here and here. That's normal. If this is the normal, we are assuming that all of these are all high. So Sam is on glucophage, is on actually 2 anti-diabetic medication. What would you advise for Sam? So someone says increase the dose. Consider a basal insulin, right? Sorry? Sam is 40s. 3 years. Sam is a driver. So what could you consider? So most likely Sam is actually worried of having what? A hypo, right? So how would you be able to actually advise him? You can try and increase the doses, or also you can actually switch and add a basal insulin, which basically reduces the blood sugars down after that. Are we together until there? So while you're found out that Sam is a driver, is having high sugars throughout, it's not only one specific time, and therefore by just putting a basal insulin, you can bring it down. The last one. Okay, just to teach again, remember we start looking first for lows. Yeah? Are there any lows? Because from here is a low. Any lows? No. Then you look for pre-meal highs. Are we together until there? So breakfast. So breakfast would be around here. Any high? After breakfast? Okay. This is actually sort of pre-breakfast, after breakfast. Pre-lunch, after lunch. Pre-meal, pre-supper, after supper. Okay? So, next thing, the next day we talk about pre-breakfast, after breakfast, normal. Pre-lunch, after lunch, normal. Pre-dinner, after dinner is high. And that's the same pattern that you're actually getting on day 3. So Pete is like many of us. Leaves the house very early, so eats the breakfast, goes to work, rushes, works all day, has no time to have lunch, like a big lunch, so takes a small lunch, then goes home and has the main meal when? Dinner time. So what would you advise Pete? Pete now is on two medications. Antidiabetic medication. Any advice you give Pete? Would you consider that maybe Pete can change the highest, the meal, that as much as possible, maybe the biggest meal to be breakfast? Anything else you would ask Pete to do for dinner? Eat less? Anything else? Huh? Don't skip meals so that he doesn't have to eat a big meal in the evening, right? But that's what actually structured testing gives. Now, tests are not cheap. I mean, blood sugar testing strips are not cheap. That's true. So when you do it, you want to do it, it gives you information that you can be able to act on. And then after that, you can use that information, you don't have to check as much. So I believe that if you can be able to check pre-meals, post-meals, pre and post, you're able to actually act on it immediately and be able to have a concrete action plan after that. And once you do that, what happens? If your blood sugars are on target, that means your HbA1c will be lower. True or false? True. And that decreases the chances of, if you have any microvascular complications, it either regresses, halts, or it doesn't progress after that.
So my name is Nahida Adam, and I'll be introducing the practical insertion of continuous glucose monitoring, which is one of the devices that I use for that we have, for Medtronic diabetes. So why CGM? So CGM, as you can see in this graph, it helps basically complete the picture. It reads every 5 minutes, 288 times a day, giving really good glucose trends of the individual that we put on a CGM device, which means continuous glucose monitor. So with this, you can actually see that you can understand or have a more comprehensive understanding of the patient's glucose trends, uncover potential dangerous excursions that are in between the finger prick testing. So this helps make necessary adjustments for your patient's therapy for better health and safety. So there are 2 types of CGM, defined by the American Association of Clinical Endocrinologists. There is the professional CGM, as you can see on the left side, and the personal CGM. So the personal CGM, I'll just cover briefly, is basically a CGM device that's owned by the patient, and it provides a display of real-time glucose value and glucose readings of the individual. This has alarms, this has alerts, this helps the individual better understand what to do next in the current situation that they're in, with the help of the personal CGM device. So what we'll be focusing on today is the iPro 2, which is a professional CGM. So this is designed for the healthcare professionals, so you'll find it in the hospital or the clinics, and it's a mass collection of glucose data. So there's no alarms, there's no flashing lights, to tell the patient what's happening. It's purely based to give an unbiased assessment of the patient's glucose monitor. And it could be put on between 3 to 6 days, which basically, the more information the doctor wants of the patient, the more longer they'll put it on the patient. So this assessment is very good at helping to understand the patient's lifestyle. Let's say their diet, their sleep, their daily activity, medication, and behavior. So iPro 2 helps utilize the CGM to uncover all those glucose patterns, making it very fast and simple to use. And it's also a really good how do I say, a really good discussion to have between healthcare professional and patient to better understand the patient regimen. So, according to the AACE, although I believe iPro2 is, can be used on all types of diabetics, but because iPro2 gives a lot more information on the glucose trends of the individual, this is what is recommended as a good target to put on these types of patients. So patients who are not meeting the HbA1c target, that they've tried everything that the doctor recommended, but for some reason they're not meeting their target. If they're having any hypo or hyperglycemic unawareness, Dawn phenomenon, postprandial hyperglycemia, all pregnant women also over here that have type 1 diabetics, and any also treatment adherence for women with type 2 diabetes, or insulin requiring gestational diabetes. These are the more difficult to treat patients, I would say, and also to get a better understanding of the glucose or glycemic patterns of these individuals would be most beneficial for iPro2. So the areas of insertion are any areas where, there's a good, I don't know why you can't see the gray areas. Can you see the gray areas? Okay, so it's showing there. But any area around the tummy, at least 5 inches, 5 centimeters or 2 inches away from the belly button area, where basically anywhere where there's a good fatty tissue. The upper buttock area over there, the sides of the back of the arms, and the sides of the thighs. So I think that should have been showing there, so I'm sorry it's not. So those are the areas that are recommended for iPro2 insertion. Oh, and these are the areas we just try and avoid the belt line, anywhere that will cause irritation of the site. And if the body bends a great deal, anywhere where your stomach folds in, that's an area to avoid. And anywhere where there's scarred tissue, hardened tissue, or stretch marks, somewhere where you might feel that there's not good enough tissue flow of the individual. So I'll talk about the components and the insertion of iPro2. Okay, so the glucose control takes 3 main steps, 3 simple steps, I would say. The first step is the patient setup. I'm really sorry about this because this should be a bit like, maybe we can darken it or something, but this is meant to be a glucose sensor to show here. And this is the glucose inserter device, and this is a charged iPro2 transmitter. These 3 items are what is needed to insert onto a patient and, for the iPro2 assessment. So the area that we choose, we just clean the area with an alcohol wipe. We use the glucose inserter to insert the glucose sensor onto the skin, and then the iPro2 transmitter is connected to the neck of the glucose sensor. As soon as the iPro2 is connected to the glucose sensor, the iPro2 usually flashes green to show that it's connected and ready to use, and that's the only time it will flash. So here's a link that I would like to kind of select and show you the video. So I'm hoping it works. So we'll play the video just to kind of show you a practical demonstration on the iPro2 insertion. So the patient's data is downloaded onto a software called CareLink iPro. So it's an online software, so you need good internet connection to do the download. After the data is complete, the iPro2 is automatically erased and ready for use for the next patient. So when the iPro2 is downloaded of the patients, you automatically get 4 PDF reports that are downloaded, and you get these 4 PDF reports called the pattern snapshot, the daily overlay by meal, and daily summary. So these is fast, simple, and easy to download. You just do it and insert the patient's details, and then you're good to go. I'm not really going to go into the results too much. That will be under another discussion. But this is just an example, and I'm really sorry about this, but this is just an example of a pattern snapshot. Just to show you, I hope you can see the dark part. Maybe I'll focus on that. But here it's showing different regions of the graph to kind of give you little kind of questions over here to hint maybe what kind of questions to ask the patient, because this individual is having quite a high, a varied glucose glucose reading basically results. So there's a few questions here which highlight maybe, you know, what to ask the kind of questions to ask the patient in terms of the data shown here and in the different regions. The daily overlay and the daily summary is over here. Okay, so I'll just describe it to you because it's really light and I don't think it shows much. So daily overlay is the whole time that they've had it on, the whole 6 days over here, is all compressed into one data, one 24-hour graph. This is just to notice if there's any glucose trends that you've noticed within that week that they've had it on, or 6 days that they've had it on. The daily summaries, each of these days are broken down per day to show what's been happening, you know, on each day. And then you can actually conversate with the patient on what's been happening with them. This is just a daily overlay by meal. Over here should be 2 bars to show the breakfast, lunch, and dinner times. These are all flexible when you insert it into the into the CareLink iPro software. And this is the nighttime reading also. It shows what's been happening at night of the individual's glucose patterns. And it's quite detailed, basically. So whatever the doctor wants to focus on is usually decided upon them. So just an overall finishing point of the value of professional CGM. So it's labeled for anyone with diabetes, iPro 2. So it's really good in uncovering the patient's glycemic patterns, then, you know, any nocturnal lows, any dawn phenomenons, and just for better understanding of the healthcare professional and the patient's own data. It's also with the studies that has been shown in all types of individuals, adults, pregnant women, and pediatric patients. As you can see, it helped reduce HbA1c without hypoglycemia, identifies more nocturnal hypoglycemic episodes than anticipated, and identified dramatically more glucose variability than previously expected, and also assisted in reducing the risk of macrosomia within pregnant women. And overall, 8 out of 10 patients has seen better glucose control and felt more engaged with their more engaged with their physicians, therefore reducing healthcare costs while achieving good quality care. And that's it from me. Thank you.
It's basically approach to the young child and parent approach to the young child and the parent with the young child with diabetes, and what's the best structure for continued care. Okay. Yeah, so basically I'll just jump into it. There are a lot of challenges when dealing with children, and as we know, children are not young adults, much as we'd like to think so, but they're not. DM in children usually is type 1. There's now, as first speaker pointed out, we are also getting a bit of type 2. We are yet to document locally, but with the rising of obesity, the children also developing type 2 diabetes. And this is usually very difficult to convince parents that, yes, your child has diabetes and will need insulin for the rest of their life. So breaking the news to the parents is that this is a major chronic illness in a young child. Oops, I'm sorry. Yeah, is something to grapple with in the beginning. Then, of course, overcoming needle phobia in the children is another challenge we have to cope with. Then there's the diet plan to enable these children to not only to grow, but also to manage diabetes appropriately. That's another challenge we have to face. And then, of course, need to facilitate uninterrupted learning, because these children are in school. Some of them have not even reached college. Of course, most of them haven't. So you really want to make sure this child continues their education uninterrupted. So as much as we want close monitoring of children, we want to make sure also we don't interrupt their schooling. So it's really a balancing act when you're dealing with the children. Now, just basically looking at what some of the recommendations are that guide us in this work. The blood target range for children, what's recommended for the children and young adult. Before meals is 4 to 7. And after meals, 2 hours after meals, maybe 5 to 9. But of course, we set closer targets the older they become. Now then, you have to decide which insulin regimen are you going to choose to manage these children. So basal bolus, really, or continuous subcutaneous insulin infusion is the way to go because it closely resembles what the body does in real life. Then whether to use analog or human insulin is usually left to the prescriber, and of course you have to consider the cost and affordability of this regimen that you'll choose. Now, all patients really should be offered basal bolus insulin. Why? Because, as I said, it is closest to what the body is doing. Because if you opt for twice a day, the mechanism is completely different from what's happening, and you'll have a lot of hypers and hypos. So actually the teaching is now do not really offer them, unless there's no other choice, do not offer these children twice daily regimen. As much as it will be comfortable, it will be very convenient, but it will not be convenient for the child's body. Rapid-acting analogs are the choice for meal times because of their quick onset of action. Now, basically just flying through the new guidelines so that we are on the same page. Basically, it's emphasized more on the primary care as opposed to hospitalizing all these children in the major centers. We're moving more towards peripheral care of the patients as much as possible because you can't have all of them having to one major center of excellence for continuing management. So basically structured education for all patients, beginning from the patients themselves, of course, to the care providers. We still advocate, of course, for annual checkup because type 1 diabetes is an autoimmune disease. So along with it come other riders, can come other riders like thyroid and Graves' disease, Hashimoto's disease. You can also be on the lookout for celiac disease. So any associated autoimmune diseases would be screened for. In our setup, we don't routinely screen for celiac disease. One, because it's expensive. You have to outsource it rather. And a lot of times you screen for it, it's negative anyway. So one would tend to be guided by the symptoms of the patients. So all children with type 1, they require insulin therapy and of course regular blood glucose monitoring. Now these come with added cost effects. Blood ketone testing is recommended. Not most centers can do ketone testing. In fact, very few glucometers are able to test ketones rather. You need also a well-organized multidisciplinary team to look after these patients. And if possible, share appointments so they're not spending the whole day going from one specialist to another or different days in the week. Yeah, so basically, these are the items that we are involved in. As we all know, we need to manage their diet plan, we need to monitor their glucose, we need to administer insulin. And we've already seen a bit of this demonstrated by the previous speaker, the glucose monitoring. Ideally, it should be 4 times a day, as the first speaker pointed out, before, after meals, so that you can see the pattern of what's happening with the blood sugars. Sorry, sometimes it's stubborn. Can't move when he wants to do. Okay, so basically, I was saying what happens in real life is what we are trying to mimic. How after the meal, the blood sugar shoots up, comes down, snack, and all that. So what we do with the insulin is to actually imitate what the body is doing, give our boluses of insulin with the anticipated peaks of blood sugars. Okay, this was just to show you the different modes we have of administering insulin, the good old vial and syringe. Then there's the pen, and how you administer with the pen, and then there's the pump plus continuous glucose monitoring in situ. Oops. It's the most stubborn thing you've ever seen. Anyhow, so what's the best structure for continued care of these children? It's a multidisciplinary approach, as we said. And there's the evolving role where the care provider collaborates not only with the clients, but also with the rest of the family, of course, and the idea is to optimize their insulin levels, blood sugar levels, with the aim of reducing long-term complication. Yeah, so I wanted to go into that, but I think my time is not really going to allow us to do that in detail. So basically, this is the diagram I wanted us to look at. So there's the patient-centered care, which encompasses that partnership that we talked about. If we can share their medical appointments to reduce the time spent in the institutions and the time they spend off school. We share decision-making. You don't just dictate it. What is affordable for this family? You can't come up and say some unaffordable meal plans or whatever. So really, what is affordable so that it can work? And then, of course, multidisciplinary approach. And we have this motivational interview training for diabetes care for the patients themselves. And basically, it's teamwork and also in a patient-friendly way. I think we'll have to leave it there. Sorry, the thing is a bit stubborn, but my time is gone. So in short, this is the team. If I can just show you that quickly, then I run away. This is the child himself in this team, followed by, okay, time up.
Thank you, Dr. Limbe. Sorry for that short duration, but in this session, we'll be having short talks, around 5 minutes, and at the end of the session, we'll have a 20-minute interactive session. So please, if you have any questions, note them down so that we'll be able to ask the speakers at the end of the panel experts session. Our next speaker is Dr. Rosemary Ochieng. She's a pediatric neonatologist at the Aga Khan University Hospital, and she'll be speaking to us about the key issues that they face for neonates with mothers who are diabetics. So welcome, Dr. Ochieng.
Do you want to just guide me through that thing which was not working? Morning, everyone. As you've heard, I have 5 minutes, so hopefully I'll be able to say, okay. Oh. Okay, so I'm basically going to take us through a few issues that we look at when we are confronted with a diabetic mother. What are the considerations when we want to manage the baby? And some of the things we look at is what kind of diabetes is this? Is it gestational, as in the mother was okay previously, but this is discovered through pregnancy? Or is this somebody who's long had diabetes and then is pregnant? And for either of them, how was the control? Is it controlled just on diet? Is she taking oral hypoglycemic agents, or is she on insulin? And these are some of the considerations which we need to be aware of, because they determine not only the complications, but even how we handle her baby when the baby is born. Now, the risks can be during labor and delivery, or immediately post-delivery, and we even have some long-term complications. During labor and delivery, obviously, a mother whose diabetes is not well controlled can be macrosomic, and that increases their risk of prematurity. It also increases the risk of perinatal asphyxia, because this mother may not be able to push this baby within the duration required, so that you have second stage issues. And they have an actually almost 30% risk of having birth injuries, again, because of the hypoxia, macrosomia. Now, more peculiar to pre-existing diabetics is the issue of growth restriction, which is not so common in mothers who have gestational diabetes. So we can end up with either macrosomia or severely growth restricted babies, some even less than 2 kilos at term. They also have an increased risk of congenital anomalies, especially if the diabetes is not well controlled. And for pre-existing diabetics, the congenital anomalies can be severe enough for them to even have first trimester abortions. But some of the more commonly encountered anomalies are to do with the heart, which thankfully resolve within 2 weeks if they were not severe enough to cause any issues. But they can also have things like spina bifida, anencephaly, GI atresia, and such. So it's actually really, really important to us how this diabetes was controlled. The immediate risks which we look out for at delivery, one obviously is the hypoglycemia, especially for mothers who had insulin to control their diabetes. Then you find that the babies tend to have very low blood sugars, which can end them up with even seizures. They are also prone to polycythemia because of, as a part and parcel of the macrosomia. And partly because of the respiratory, because of the prematurity, but also because of the insulin action on the development of the lungs, a lot of them end up with respiratory distress syndrome. So you can find this 4 kg baby being ventilated because of RDS, and sometimes it's a bit hard to convince the mothers that this baby is this big, but basically behaving like a preterm infant. Late complications, we have an increased risk of type 2 diabetes, especially the ones who are macrosomic. Obesity can also be a complication. And then complications arising from the earlier illnesses, such as the RDS and prematurity. And of course, if they had perinatal asphyxia, then they can have complications because of that. So management, obviously, prenatal care is essential for strict glycemic control. Early initiation of feeds for management of the hypoglycemia, monitoring and correction of both hypoglycemia and hypocalcemia, and identification and care of complications later. I think that's it. That's just one of the ways we ensure that the blood sugar stays okay. Thank you.
Just to share a few studies that have been done by our postgraduates in Kenyatta with regards to screening for gestational diabetes. And this is a study that was done in 2010. And just to show that 16.7% of the patients met the diagnostic criteria for gestational diabetes. In this case, she was using the 100-gram 3-hour glucose tolerance test. The factors that were associated with glucose intolerance were body mass index of more than 25, family history of hypertension, and history of infertility. This is another study done by Dr. Bosire. This was in 2012. He was using the 50-gram glucose challenge test and the 7.2 millimoles. Found that gestational diabetes was 11.6%, and if we use the cutoff of 7.8, it was 8.9. So still very high figures. And risk factors here, this risk factor screening was noted to have a low sensitivity and specificity. He went on to, after the screening test, would do the glucose tolerance test print. But this is a study which is published last year in 2017, a study that was done in Western Kenya looking at the prevalence of gestational diabetes. Basically here what comes out is that in the population-based, the gestational diabetes is very, very low. It's what they found, I think was 2 point something. And the point of care testing was found to be having a poor sensitivity for screening. So with these thoughts in mind, I'm going to show you what we do at Kenyatta, or we do or we do not do, and what we should do. Maybe coming to this conference has made me think of many things that we are not doing right, so I will confess to that. So, somehow your things come out very nice on the sides, but not here. So these are the Ministry of Health guidelines with regards to obstetric and perinatal care. The last guidelines are of May 2012. They talk about risk assessment at the first visit and do an oral glucose tolerance test, sorry about the typo. And if it's normal, we repeat at 24 to 28 if a patient has risk factors, the usual, BMI and previous bad obstetric history, previous macrosomia, family history. They also recommend that you could do a fasting blood sugar, which is if it's more than 7.8, or random blood sugar. So we in Kenyatta sort of do risk screening. We do not test everybody who comes to our hospital. I want to share with you the statistics for Kenyatta. On a typical month, I just picked February 28, 2018, we would see like 370 new clients in the antenatal clinic. But the women who come and deliver with us are only 20% of the ones who come to, the 80% are from everywhere else. And the statistics for the number of diabetics versus gestational, we don't sort of have records on who is gestational diabetic and who is diabetic over the years that we see here. And we have from around 77 on a maximum, and then 2017, 2018, the figures are affected because of the several months of industrial action and not working. So this is the sort of figures over deliveries of about 15,000 deliveries in a year, okay? So what are the issues at Kenyatta? So first of all, to admit, we do not screen patients routinely. We do risk assessment, and we may not be doing it very well because of the numbers that we see. So we do not have Kenyatta-specific guidelines. We are following the Ministry of Health guidelines. So maybe as a tertiary center, we do need to develop our own guidelines. Laboratory tests are not covered by NHIF at the moment. Antenatal care, we used to have what we thought was free maternity services, but it's not really free. Antenatal care is not covered. Tests, lab tests are not covered. So what are the logistics of carrying out these tests? Of course, do we do glucose challenge and then do the glucose tolerance for those who need it, or do we do glucose tolerance for everyone? It's about 600 to 800 shillings in Kenyatta. The expense the patient has to bear. Maybe we need to think of negotiating with NHIF. There is negotiation to include the other blood tests, but unfortunately the glucose challenge or the glucose tolerance test was not discussed. Maybe we need to get that and then move on to the next step. Now, what are the issues with managing these patients? Of course, we need nutritionist support. We have a nutrition department, and that works out well. We have all the clinicians in the Department of Clinical Medicine Therapeutics. They do come in, especially with the diabetics. Gestational diabetes, of course, we would not admit them, then on an outpatient basis to connect them and make sure that they have incorporated the lifestyle changes requires a lot of support from the others as a team effort. And then whether they will require just dietary control or they will require oral hypoglycemics or insulin, of course, will become a little more complex as things move up. Postnatal follow-up and 6-week gestational diabetes testing will, I think, be another challenge, because usually these patients, in the public sector, they do not even come back to the facility they were in. They'll go to the nearest. So I think all these are going to be issues that we will really need to sit down, grapple with, calm down. And maybe to start off, I think we need to start collecting proper data on what sort of numbers are we seeing with diabetics and what sort of numbers we see with gestational diabetes. So thank you for inviting me and making me think about what we need to do correctly.
In my mind, I thought it would be more of an interactive session where this panelists will be here, and so I did not prepare a presentation. And the good thing, again, for not preparing slides is that the audience focuses on the speaker. and they focus on the words, and they don't struggle reading through what the speaker is going to talk about. So maybe I'll organize it in 3 areas: preconception, before the woman gets pregnant, then the woman gets pregnant, then there is delivery. So those are the only 3 areas. And Dr. Roslyn Ocheng said the first thing we have to differentiate, is it a woman who has diabetes? Is she already diabetic? Is she entering pregnancy with either type 1 or type 2 diabetes? Or is this diabetes gestational, meaning it has been recognized first or onset during the pregnancy? But remember, the International Society on the Association on Diabetes and Pregnancy Study Group found that it's difficult at times to differentiate between women who are already type 2 diabetes and getting into pregnancy. And that's why they came up with a 2-phase strategy of screening. So preconception, what are you talking about preconception? It's very important that people who are mandated to offer healthcare to women, that we start off with preconception clinics or preconception affairs before the woman enters into pregnancy. The important thing in diabetes is screening yourself, or having that idea that I'm at high risk and I need to do something before I enter pregnancy. So pregnancies should be planned. 50% of pregnancies we know are not planned. But what we are urging women, and especially women who have high risk with getting gestational diabetes or are already diabetic, either type 1 or type 2, they plan to enter pregnancy when they are in good health, what is called pregnancy fitness. Early screening. So are you at risk? Do you have a first relative who is diabetic? Or what about your weight? Are you obese? All right? And your BMI, more than 30 kg per meter squared. Are you entering pregnancy when you are an advanced age? Maternal age is important, more than 38 or in their 40s, okay? Have you delivered previously a large baby, probably more than 4.5 kg baby, all right? So there are quite a number of risk factors. Do you suffer from polycystic ovarian syndrome or polycystic ovarian disease? So these are some of the things you have to look for before even you enter pregnancy. So at the preconception period, that is important. And then the role of supplements. We know there are many things that you can do, that you can take, but things like folic acid or omega-3 fatty acids, probably those are the 2 which have been studied extensively, which can make a difference. Medications. If you're type 1, type 2, so you'll need medications to either be changed, your glucose monitoring to have been looked at before you enter pregnancy, so that, as I say, you enter in that fitness that you are able to sustain pregnancy. So all these things have to happen preconception. And that's why we are talking now of preconception clinics, pre- and periconception clinics. That's a concept that healthcare providers have to embrace now. Now you're pregnant, the woman has entered pregnancy. Early screening is important. As I say, DPSG suggests a 2-phase strategy for screening. Early screening, first antenatal visit, first contact with the client, screen them, okay? Look at the risk factors, age, BMI, then the other known risk factors that you know very well. And there are cutoff values for early screening. And if they are either the overt diabetics, or what I call, maybe they are already type 2, or they have gestational diabetes, or they are negative, they don't have. And then you'll rescreen them at 24 to 28 weeks. And we know there are, of course, issues with screening. There's so much debate about screening. Do we do universal screening? Do we do selective screening? Which one do we use? Do we use the 1-step, or do we use the 2-step? All those are still controversies. And what about the cutoff values? What cutoff values are we using? And we know with the HAPO study, the cutoff values were lowered. And that had implications, including many women who are going to be labeled as gestational diabetics. And what number of values are we talking about? So those are still controversies. And then the role of treatment. So screening has its issues, but in our setup, we follow the International Association of Diabetic Study Group strategy. We rely so much on that in our setup. When the woman is pregnant, the important thing is the multidisciplinary care. So you must have these people with you, the dietitian, the physician, counselors, nutritionists, and the neonatologists. Sugar control is key, and we have values, okay? The values are clearly known, what the postprandial sugars should be, what the fasting sugars should be, and how control should be achieved. Ultrasonography also has become important, and it has also been used to adjust treatment. We don't have very good quality studies to inform timing of delivery. But overall, what we say is that we rarely will deliver women before 38 weeks. When the women come to me, the first thing I usually tell them, let's target 39. But depending on your circumstances, we could deliver you earlier, depending on a sugar control, depending on other complications, depending on patients' preferences and circumstances. But target 39 weeks. And I know in other units outside this country, very well-controlled gestational diabetic women, they can go up to 40 weeks, up to term, and they get delivered. What we know is that there's a place for cesarean operation, especially for macrosomia. Babies who are more than 4.5 kilos. There's good quality evidence suggesting that you'll prevent permanent brachial plexus injury. And there's some people who calculated the number needed to treat or to harm. If you did 588 cesarean section, so you'll be able to prevent one brachial plexus injury if you're doing it for an estimated fetal weight of 4.5 kilos. So if you're estimating serial ultrasound growth and you reach 4.5 kilos, then there's room for cesarean section. Then there's delivery. As I say again, in the labor room, it's multidisciplinary. You have to involve the physicians, you have to involve the neonatologist, you have to involve the anesthetic team. You want to prevent simple complications or complications which can occur easily, diabetic ketoacidosis especially. So good sugar control during labor, good fluid balance, and eventually you'll achieve a good delivery. And again, post-delivery care, and another speaker will talk about what we do after delivery. So I think in the interactive session then you'll have to pick up current issues or issues which are of concern or issues which have controversies, and we'll be able to clarify. So thank you very much.
And I'm going to be talking about gestational diabetes and diabetes in pregnancy outcomes and the postpartum care. So this is our basic objectives that we're going to be talking about. A little bit of intrapartum management, which has been talked by my counterpart, Dr. Masana. Monitoring and management immediate postpartum, postnatal screening and postnatal care, and the future outcomes. So one of the things that come into management discussion is about the timing. You've heard Dr. Masana and Prof. Qureshi talk about this, but in a guideline basis and based on what we naturally practice, I mean, we have this as a guide, type 1, type 2, on treatment with no major complications during pregnancy, including neurologic or retinal or renal outcome complications. Your target is between 37 weeks and 0 days to 38 weeks and 6 weeks and 6 days.